I want to welcome everybody back if you were with us yesterday and welcome you for the first time to day 2 of our third annual conference on precision psychiatry. I'm Jordan Smoller from Mass General Hospital. Delighted to welcome you.
You see there's no difference between the green line, which is the placebo, and the blue line, which is ketamine. But that ketamine is increasing sensory evoked potentials in patients who do respond to ketamine. And this is probably the most direct evidence of restoration of the synaptic.
One of the new studies in the UK is called Our Future Health, where, and I'm a participant, but they are recruiting 5 million people and who will be followed with electronic health records and have genotype data available. And once we get to that sort of numbers, that's about 10% of the UK adult population. I think that's going to be a huge driver on both the research and the clinical side.
Informing how this gets to the to patients in a way that is accessible, because I think causality is easy to understand. These probabilities are hard, and for many people, and so I think that providing the appropriate sort of educational tools for physicians to inform patients about what this actually means is also a really critical piece.
There's risk, and then there's high risk and very high risk. So again, this framing of how we're going to go forward is something that we need to think carefully about, but I think is something that, again, we can move forward with and give this information in a safe and effective manner.
But I hope I've convinced you that some of the outcomes that are not risk itself, but prognosis and treatment outcomes might be better targets to aim our genetics at.
So in other words, this verbal IQ decline was associated, we found, with a 3.5-fold increase in risk for psychosis, so quite a robust predictor.
It's prudent to stay with simpler models at the moment where we are, and which are more controllable and also might help from a bird's perspective to inform the development of novel treatments. So because they are more interpretable.
It depends on how different the subgroups are from the main groups. And so the more they are different, and there can be all these different factors, genetics, sociocultural, and so on and so forth, the more they are different, the more we will not be able to analytically account for it without appropriate sampling. But, and that gets me back to my first point, if we can quantify the degree of uncertainty, the gap, if we cannot quantify that, then I think we're not well prepared to even go in this research. Maybe do something that's entirely data-driven, and we just optimize prediction of the clinical endpoints that we care about directly, because that may be faster, more cost-effective, and more pragmatic.